Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, this is our second lecture in cardiac pharmacology, we're going to go pretty in depth into the medications and the pathophysiology of angina and MI. So let's start with some pathophysiology. Angina, or sometimes pronounced angina, is when oxygen demand exceeds supply in the heart. So what does that mean? Typical case scenario, let's say a patient who's pretty out of shape, they go for a little jog and they come back, or they're mowing their lawn or shoveling the snow, they come back and they're really short of breath. So what happened there? Well, when they exercise, which is when they did a walk or mowing the yard, when they did that, they were exercising, so their body needed extra energy. Because their body needed extra energy, it needed extra oxygen. Because it needed extra oxygen, the heart had to pump extra to deliver that. Now, the heart in that patient is out of shape. Literally, it's out of shape. It's not in good physical health. So, because it's not in good physical health, it is unable to keep up with that increased demand. Because it's unable to keep up with that increased demand, let's take it a step further and really understand what's going on. So the heart is being asked to pump faster and harder than usual because the body needs extra energy, because the person's exerting themselves. Because the heart is being asked to pump faster and harder, it needs more energy. However, how does the heart, get more energy? The heart is supplied energy, it's supplied oxygen by the coronary arteries. If the coronary arteries are unable to deliver enough oxygen to the heart itself to meet the increased work that is demanded of the heart itself, then we end up with angina. So one more time, when the body is exerting and needs more oxygen delivered, which means the heart has to pump harder and stronger. If the heart is not physically capable of doing that, because when the heart has to exert itself, it needs extra energy supply, extra blood supply through the coronary arteries, the right coronary artery, left anterior descending, whatever those are. Because it needs extra blood supply and the heart can't deliver it, it becomes hypoxic. What does that mean? It means the cells are wanting oxygen and they're not getting it. That is called hypoxic. Another word for that is ischemic, and we'll talk about that in a second. So it's a demand problem. It's also a supply problem. The heart is demanding, doing this extra energy and demanding extra oxygen, and that extra oxygen can't be delivered to the heart. At the end of the day, very simply, it's a supply and demand problem. What does that present as? It presents with chest pain. Why? Because the heart is demanding extra oxygen. The cells are not getting, the cardiac cells are not getting this extra oxygen delivered to it. So the cardiac cells become hypoxic. The cardiac cells are not getting their oxygen, and hypoxia in cardiac cells leads to chest pain. Do keep in mind that even though chest pain is one of the top 3 most common causes of emergencies in the United States, of ER visits, of EMS calls, it is by far unlikely that the patient's having a heart attack. We very often find that it's other things such as panic attack, musculoskeletal, GERD, and many other causes of a patient having chest pain other than what I'm exactly describing. However, because that is the most significant risk, we always assume that chest pain is cardiac until proven otherwise. And when I say cardiac, the cells being hypoxic. Let's move on. So when a patient does have that their cells are hypoxic, then we want to fix it in 2 ways. We want to increase their supply and decrease the demand, and we'll get to that in just a little bit. Let's talk a little bit more pathophysiology and diseases. Stable angina is when chest pain comes in a predictable pattern. For example, they know every time they go out for a 5-minute jog, they come back, they're short of breath, they have to sit down for 10 minutes. That's a predictable pattern. There is something called unstable angina, which I'm not going to get into that, which would be where the pattern changes. The pain, like I said, is predictably relieved with rest, or sometimes they have to take nitroglycerin, which is what we're going to get to in just a few minutes. A MI, a myocardial infarction, let's talk about the pathophysiology there. A heart attack, also known as an MI, is caused by an obstruction in one or more of the coronary arteries. We talked about the coronary arteries, the right coronary artery, left anterior descending, the circumflex artery. These are the arteries that supply blood to the heart itself. And if you didn't know that, that happens during diastole, where the whole rest of the body gets their blood delivered to them during systole. The heart gets its blood flow during diastole. That's neither here nor there. But what happens in an MI? An MI is where one of the coronary vessels has an obstruction, a blockage. Almost always it's caused by plaque. Sometimes it's caused by a clot. Sometimes it's caused by both. When I say plaque, I mean a buildup of cholesterol, or a piece of cholesterol, a piece of plaque that maybe has been sitting in your artery somewhere since you were 5 years old. Then all of a sudden it goes and takes a trip down the blood vessel until it gets lodged in one of the coronary arteries, causing an obstruction. That's the typical pathophysiology of an MI. Like I said, this will cause all of these cells distal. All the cells past this obstruction to now become hypoxic. Why? Because they're no longer getting a flow of oxygen because the blood is cut off. Once the cells become hypoxic, they become ischemic, which means starved for oxygen. That can lead to the cells becoming injured or having actual physical damage from the lack of oxygen. If that progresses, the cells lead or end at infarction. Ischemia, which is hypoxia, is where they're starving for oxygen. Injury is the next step where they actually become injured or damaged because of the loss of oxygen. And finally, infarction, which is irreversible, is cellular death, which is the end result. So our goal, obviously, is to get the patient reperfused, meaning that part of the heart that's been cut off from oxygen supply. We want to get that part of the heart reperfused as quickly as possible. The first line treatment for a patient that is having an MI is to be treated with percutaneous intervention, also known as angioplasty. Angioplasty is where we say the patient's going to the cath lab, or if you've heard the expression, I had 2 stents placed or 4 stents placed, all of that is talking about angioplasty. So let's talk about that for just a second. What is angioplasty? This is outside of pharmacology, but I'll go there anyways. Angioplasty is where we access the patient's arteries, usually through the radial artery or the femoral artery. This is done in the cath lab. We take a device, we put it all the way up into the coronary arteries, we shoot a dye, and we look, where is the blood flowing? And more importantly, where is it not flowing? When we see where it's not flowing, let's say halfway through the circumflex artery, it stops flowing, there's the obstruction. So now, if there's an obstruction there, the most common procedure is to place a stent. As you can see in this image over here from Hopkins Medicine, you can take a stent, get it, push it through or past where the blockage is, not past completely, but past right up to, and then inflate it. When you inflate it, now that blockage sort of got pushed up against the walls and the actual vessel is open once again. So that's placing a stent. Now, if a stenting procedure is not available because the patient's in a rural area, because there's a mass casualty going on, things like that, then we have a backup option called using thrombolytics, and I'll talk about that in just a little bit. One last thing before we actually get to the pharmacologies, I want to go over Life's Essential 8. Excuse me. Life's Essential 8 came out from the American Heart Association roughly about 7 years ago. We're filming this at the end of 2024, roughly about 7 years ago. And what Life's Essential 8 is, it is the 8 key risk factors for developing cardiac disease. Cardiac disease, including the vast majority of all cardiovascular diagnoses. So what is the Life's Essential 8 and why are we talking about it here? Because a lot of them, first of all, this is patient education. Is something as a nurse or a nursing student you're going to see on exams of what you have to educate your patient. A lot of these are the non-pharmacological interventions, and a lot of these are just good things that you have to teach patients of how to avoid the number one cause of death of everyone over the age of 45. So let's go through them. Patients have to manage their diet. Patients have to get enough exercise. Patients have to get enough sleep. Patients have to maintain a healthy body weight. Patients have to quit smoking. And then the last 3, they have to manage their cholesterol, their sugar, and their blood pressure. So those are the 8 things that the AHA calls Life's Essential 8, and you can look at it more on this link that I attached in here. And this will tell you all about it and why these are the key characteristics, the key risk factors for a person developing coronary diseases, especially developing an MI. Now let's go into the pharmacology. We're starting with nitrates, which is technically, sometimes your book may call nitrates as a drug class. Sometimes it may just be put under vasodilators. Either way is correct. And this is the medication for angina. So we're back to angina for just a minute. Let's talk about it. The most common drug here is nitroglycerin. Other drugs in this class would be isosorbide dinitrate or isosorbide mononitrate. And we'll talk about those more when we get to heart failure, because that's really where those are used. The mechanism of action of these medications is that they dilate your veins, they make your veins bigger. What does this do? That increases preload. What does increased preload do? It increases the supply to your heart. Again, this is talking about angina. Angina is a supply and demand problem. So if a patient went and exerted themselves and now their cells are becoming hypoxic, not enough supply and too much demand, what do? We tell them to sit down and relax. That decreases the demand. We tell them to take nitroglycerin, increases preload, increases blood flow to the heart, increases supply. So it was a supply and demand problem. We have a supply solution and a demand solution. Very simple to understand. One thing to note, I wouldn't expect this to ever be on an RN level test, but if you do want to know that nitroglycerin at very high doses can actually dilate the arteries, and then it would cause other effects. But primarily when we're talking about nitroglycerin, certainly for angina, we're talking about dilating the veins at standard doses. Indications are going to be acute angina. We do also use this medication for heart failure. The side effects of this medication, all vasodilators have all of these same side effects: the headache, the orthostatic hypotension, the reflex tachycardia. Remember, you've probably heard me say this before. Anytime you see orthostatic hypotension, that means always educate your patient not to suddenly get up from a seated position, but rather get up slowly. And this medication is available in 4 different routes: sublingual, transdermal, IV, and PO. Now, I do want to make a few points here. When this medication is given to patients, if it's given in the acute setting where they're patient taking a PRN for angina, almost always that's going to be sublingual, either a tablet or a spray. They spray it under their tongue, or they put the tablet under their tongue and it dissolves. Either way, that's called sublingual. In the acute setting, if you are giving it to the patient, you may have them on a nitro infusion. That would be obviously IV. Also, there is another option. When you're giving it in the acute setting, you may be putting it on the patient's skin transdermally. Now, when you're giving a transdermal, this is just an FYI, and you can Google this for a better understanding, but when you're putting this on a patient transdermally, you're going to get in the package a little piece of paper that has a ruler on it, and it says 1/2 inch, 1 inch, 2 inches, and it has a line. You're going to spread the paste, the medication, the transdermal medication, you're going to spread it out on that piece of paper to however much the doctor ordered. If they ordered 1 inch, you're going to spread it out, fill up those lines up to the 1 inch mark, put it on the patient's chest or arms, and that's your medication administration for transdermal nitroglycerin. Also, patients may take transdermal nitroglycerin chronically for prevention of angina. We'll talk more about that in a little bit, but in that case, the patient wears the patch every day, all day. However, keep in mind, in that case, you do need to know that they can only wear it up to about 12 to 14 hours. They do need to take it off for half the day. They can't wear it the whole day straight, or else they build up tolerance. Also, again, due to that tolerance issue, we don't have those patients wear it 7 days a week. We have them wearing it 6 days a week. Whenever you're handling nitroglycerin, especially obviously the paste, because it's transdermal, do be careful that you're wearing gloves to make sure that you don't get it affected to you. Now, also, we don't generally test on dosages in nursing school and the NCLEX as well. However, this is one of those times where it's pretty standard that we do teach dosing here. The standard dose of nitroglycerin when a patient takes it for an acute issue, whether it's a sublingual tablet or a sublingual spray, it's going to be 400 micrograms, which is 0.04 milligrams, or I'm sorry, 0.4 milligrams or 400 micrograms. That's how much we're going to give to the patient for a single dose. The patient could get up to a total of 3 doses. If a patient's getting it, if they got to that 3rd dose, and sometimes even if they get to their 2nd dose in real life, if they're still having that chest pain, we might want to be at that point calling 911. Also, the doses must be at least 5 minutes apart. They can't be sooner than that. When we are giving this to a patient, we obviously tell them it should also be combined with rest. We want to address both supply and demand. When you are giving it to a patient, you must reassess their blood pressure prior to administering it, and obviously afterwards, because it can cause that drop in blood pressure, and very often it does. Now, do keep in mind, if a patient has a low blood pressure, you're going to withhold it and ask the provider, but the provider may very well tell you, go ahead and give it, but give some fluids with it. That is appropriate, so just keep that in mind. However, generally for RN test purposes, if a patient is hypotensive, would you withhold it? The answer is yes. This medication, the nitroglycerin, is a very common prescription. Tons and tons of people take it for their angina, and they take it without any major issues. We do have some other options that we can do if a patient is having repetitive issues of angina, and I'll get to that in just a minute. I do want to make sure that you understand that this class of vasodilators, the nitrates, they do interact with sildenafil, vardenafil, and tadalafil. That's the ED drugs, erectile dysfunction drugs, Viagra, Cialis, Levitra. So if a patient took any of those in the last 48 to 72 hours, then you should not give the nitroglycerin without talking to the provider. Also, if you see this on a test question, this medication, Nitro, is contraindicated in a patient that has a right ventricular MI, or if you suspect they're having a right ventricular MI. Also, in a patient that has closed angle glaucoma, they also would not be appropriate to get this medication. If a patient, and I already alluded to this, if a patient does become hypotensive because of their nitroglycerin, we generally treat that with giving them some fluids. Now, a patient may come and tell their cardiologist at their annual visit, I'm taking my nitroglycerin once a week. I sit down, I pop a nitro, and 20 minutes later, I'm good to go. Or they may say, I'm having to take the nitro every day for chest pain, or multiple times a day. At some point, and this is between the provider and the patient, we're going to make a decision and say, okay, instead of every time you get chest pain, you take a medication, Let's just put you on a daily medication to make this not happen in the first place. So if we are doing that, we have a few different options. First option we have, and I'm saying first here because we just talked about it, is nitroglycerin. I already said we can use nitro transdermally. In this case, we're using it for chronic disease management to prevent the patient from getting their episodes of angina. However, that is not the first line drug. The first line drug, if we want to put a patient on a daily medication, which is preventative technically, we're trying to prevent them from getting this symptoms of angina, the chest pain, because we know chest pain already means cells are starving for oxygen. We want to avoid that. So when we have a patient that we want to switch from the PRN reactive strategy, you get chest pain, you take medication, we want to go proactive, we put them on a medication. The first line are beta blockers. So let's talk for a little bit about beta blockers. We've already talked about it in our first cardiac video with shock. Let's talk about it again over here. Beta blockers slow down the heart. The heart doesn't beat as hard. The heart doesn't beat as strong. Very simply, the heart has less work to do. Again, if it's a supply and demand problem, if I slow down the heart and the heart doesn't pump as hard, the heart doesn't have as much work. If it doesn't have as much work, it has less demand. So it decreases the demand. That's how it fixes that. Let's take it one step further. Most nursing schools probably won't get into this, but let's cover it real quick. It also increases the supply, and I'll tell you why. When you slow down the heart rate, logic would say I'm getting less perfusion because I'm not beating as many times per minute. However, we do know that when we slow down the heart rate, the heart has more time to fill back up. It's not squeezing. It actually gets a half a second break in between to fill back up. Because we slow down the heart rate, the heart has more time to fill up in between each squeeze. And because it has more time to fill up, we do get an improved, at least efficiency-wise, an improvement in the output of the heart. So it can actually help the supply as well. But that's a brief overview. You probably don't have to know the supply part of it for the RN level, but do understand the demand. It decreases the workload of the heart by making the heartbeat not as fast and not as strong. The drugs we're talking about here, again, we already went through this in the last video, the first cardiac video. We have propranolol, metoprolol, atenolol, a whole bunch of them that we can use for this. The mechanism of action, we beat that one to death in the last video of shock. We talked about that this blocks beta 1. Beta 1 is responsible for making the heartbeat faster, harder, stronger. This blocks it, thereby making the heartbeat less fast and less hard. What do we use this for? A lot of different things. Here's angina, the first thing that we're talking about. Of what we're using it for. And again, we're using this for chronic angina prevention. We're not going to give this to someone who's having an acute episode of angina. It's not going to help. Side effects of this drug, it is going to cause fatigue because the patient will have a lower heart rate. So they may have less energy because of that. It will cause bradycardia because it slows down the heart rate. Beta blockers are known to cause hypoglycemia. For some reason, that's a common test question, so do take note of that. And most of the beta blockers do have a side effect of causing sexual dysfunction, especially in men over about 45 to 55. So do be proactive with that with your patients. Ask them to report if they're having any ED and refer that to the provider for treatment. These medications have a black box warning that they shouldn't suddenly be stopped. That makes perfect sense. If my heart is taking a beta blocker and it's used to this less work, less beating, less hard, and all of a sudden you stop taking it, and all of a sudden it has to beat harder and beat faster, that's a lot of sudden extra work, especially in a patient that has angina, but for everyone, that's a lot of sudden extra work, and that can be too much for the heart. Therefore, it has that black box warning that you shouldn't suddenly stop taking it. It always has to be tapered. Because it's a favorite test question, I'm going to go over this one more time. The non-selective beta blockers, which there's a bunch of them, these should be used with caution in patients that have an ongoing pulmonary issue or an underlying permanent pulmonary issue, such as COPD. And again, because this medication slows down your heart rate and lowers your blood pressure, you always have to assess the heart rate and blood pressure before you give it and after. And obviously, if you're giving it for angina, you're also going to assess their chest pain before and after. And again, we're not giving this for acute angina, just for chronic. Another drug that we have for the treatment of chronic angina is going to be ranolazine. Ranolazine is a drug that has an unknown mechanism of action, but we do know that it decreases the oxygen demand of the heart, and we use this for angina prevention. This does have a side effect of QT prolongation. And another option that we have, so that wraps up beta blockers, that wraps up ranolazine. We said nitroglycerin, and then we have one more option for chronic angina management or chronic angina prevention, or at least prevention of acute episodes, and that is calcium channel blockers, which we'll talk more about in future lectures. Finally, let's switch gears from angina over to having an MI. We said that the gold standard treatment for an MI is going to be to get the patient to the cath lab. If I didn't say this already, we want to get the patient to the cath lab and the vessel reopened within 90 minutes. That's always our goal. That's certainly a fear NCLEX question. I don't know if that's pharmacology, but that's certainly the well-known standard that we want to get the patient reperfused, the cardiac cells reperfused within 90 minutes of the emergency becoming apparent to us, meaning from the time EMS or the triage notices that it's a heart attack, or actually from the time EMS notices a heart attack or from the time the patient gets to triage. The ER were a little more strict with that. The second they walk in and get checked in by triage, that's where your 90 minutes starts. That's the national standard. And obviously it's for good reason, because we know that the hypoxia continuing will lead to infarction, which is irreversible cell death. If a patient doesn't have access to a cath lab in their heart attack, in their emergency, we do go ahead and use thrombolytics instead in most cases, not all cases. And this is always done in conference with a cardiologist, hardly ever done by the ER doc themselves. Now, the drugs that we're talking about here are alteplase, reteplase, and tenecteplase. Some schools, just so you know, may not cover this drug class over here. They may cover it over with anticoagulation, and some schools may cover it in both places. I'm going to cover it in both places. The mechanism of action is that it initiates fibrinolysis, which is the breakdown of clots. This is the only drug class, and a favorite test question, this is the only drug class that can actually break up an existing clot. Everything else, heparin and aspirin and everything else, can prevent clots. This is the only one that can break up an existing clot. The indications for this drug are 3, having a heart attack, having a stroke, and having a PE. I will give you one more. We may use this sometimes to break up a clot inside of a central line. That's really outside the scope of what we're going to talk about. That's off-label use, but just an FYI, and that's completely different. That's a tiny little dose just injected directly into that clot. This medication is IV only. This is a high-risk medication only given in ER, ICU type settings. This is given standard way to give it is with a loading dose and then a maintenance dose, usually over 1 hour. The biggest risk with taking this medication is that they can develop intracranial hemorrhage, also known as conversion. That's where the patient develops a stroke while on this medication. This medication will break down all existing clots, or at least in theory, all existing clots in the patient's body. Because that is a major deal, and the patient may have other clots that are various stages of healing from recent trauma or surgery or anything, there's always universally an extensive checklist that we use prior to administering this medication, and that is referred to as the TPA checklist. You're always going to use this, no exceptions. And what's going to be on this list is going to make sure the patient doesn't have uncontrolled hypertension, recent surgery, recent stroke, ever had a bleeding stroke. It goes down a whole list of things. Certain age requirements can be a cutoff, 80 or 85. So there's no real one standard list. Every health system uses their own, but these are just some common features, and you may see them a little bit differently. The ones that I listed are probably fair game for your school to test you on, so do know those. Also, if a patient had multiple IV sticks, either prior to or following administration of TPA, do be advised those may all be causes for bleeding. This can also cause the patient to have some irregular cardiac rhythm, so do keep that in mind if you're giving this to a patient, especially if they have an underlying history of dysrhythmias. There is a reversal agent, as you can see listed here, if we end up in a case where a patient starts bleeding while they're taking this. Now, let's just talk just for the last few minutes of what other medications are given to a patient having a heart attack. We're going to start with aspirin. Every patient in the United States who is diagnosed with a heart attack or even suspected of having a heart attack is always treated with aspirin. This is 324 milligrams chewable aspirin. If the patient already took it at home, that's the most common reason why we don't give it. The second most common reason would be if they're allergic. Next medication we have on here is nitroglycerin. Nitroglycerin, really the only contraindication of when not to use is if the patient already took it, if they had that sildenafil, vardenafil, tadalafil, or if they are hypotensive. Other than that, pretty much anyone who has cardiac suspected chest pain is going to get nitroglycerin given to them in the course of their having an acute MI. Next, if the patient is diagnosed with an acute MI and they're heading off to the cath lab, almost always they're going to get put on an anticoagulant such as heparin. They may also get put on an additional antiplatelet, meaning in addition to aspirin, and that would usually be clopidogrel or ticagrelor, more commonly known as Plavix or Brilinta. Again, that depends on the cardiologist, depends on the healthcare system. This medication, the antiplatelet and the anticoagulant, are to prevent further strokes and heart attacks, not to fix the current one. Again, and next medication we have is a statin. That's obviously a very well-known cholesterol medication. And almost always a patient who is diagnosed with a MI is going to get put on a statin, probably for the rest of their life, but very often it will start immediately upon diagnosis of a heart attack. Another medication I didn't list here that is very often started immediately upon diagnosis of a heart attack is a beta blocker. There's a lot of data that shows increased survival, improved morbidity and mortality from taking a beta blocker right away, starting at the diagnosis of acute MI. I do need to talk 1 minute just on oxygen and morphine. The main thing I want to point out here is oxygen and morphine are both 100% given to patients who are having a heart attack if they need it. If the patient's not having any pain, there's no benefit to giving morphine. Has been some thought of that in the past. That's not in the current guidelines. Same thing with oxygen. Oxygen was previously universally considered, and we're talking about 15 years ago, to be given to everyone who is having a heart attack, with the logic being they're hypoxic, they need oxygen, let's give them oxygen. We know today that's a bunch of garbage. They have a blockage. You giving them a bunch of oxygen doesn't help it get past that blockage. So we give patient oxygen if they're in respiratory distress, if they have a low pulse ox, otherwise there's no reason for it. And same thing with the morphine. If they're not having chest pain, we don't give it. If you have any questions, please reach out. Otherwise, have a great rest of the day.